Hi everyone, very good evening guys. I hope I'm audible and visible to all of you. Let's get going with question 1. There was a patient with a typical history of TB, I would say, and you had the typical Langerhans giant cell. How did I identify the Langerhans giant cell? Because of the arrangement of the nuclei at the periphery, right? Now they asked you that, okay, it's a Langerhans, it's TB. Of course, you're thinking of granuloma, and granuloma is to do with interferon gamma. So you are now going to tell me everything about interferons, alpha, beta, and gamma, where they come from, what they do, and that's your revision. So interferons come from LFT. So interferon alpha comes from where? It comes from leukocyte. Interferon beta comes from where? It comes from the fibroblast. And interferon gamma comes from T helper 1 cells, which they ask you maximum questions on. So if you are saying that interferon gamma, G for G, is responsible for granuloma and giant cell formation, so they can either ask you that in TB, which interferon is working? It is interferon gamma. In TB, which T helper cells are working? If that question comes, that is going to be T helper 1 cells. And TB is which kind of hypersensitivity? Type 4 hypersensitivity. So now if I ask you that in type 4 hypersensitivity, which T helper cells and which interferon is working? Answer is still the same. So you're stuck in that loop where multiple questions can come and your answer remains the same. Talking about interferon alpha, beta, gamma, doing the work alpha, beta, gamma. So interferon alpha is going to have antiviral properties. Anywhere they say there is a viral infection, you want to give a topical cream or an injection. For a viral infection, you will give of interferon alpha. Interferon beta I do with brain. Many a times it is used for the treatment of multiple sclerosis. But for INI-CET, thoda sa extra information to we have to know na. Do you know interferon alpha mainly has antiviral properties, but interferon beta also has antiviral properties, because in INI you get a lot of questions, A and B are correct, B and C are correct, you know, those multiple options one. So remember, the antiviral property is actually shown by both alpha and beta, but single best answer is interferon alpha. Now coming to the next question, which was on a very simple one, but this came in the recent INI-CET 2 years ago. So I felt that even if it's simple, we need to revise it, because one question of apoptosis they're liking to give for some reason. They're pretty obsessed with the topic. Apoptosome binds to what and which of the following molecules? Apoptosome is associated with procaspase 9. So everything about apoptosis that you have to revise. First we'll start from this. All the caspases that you will be telling me. In apoptosis, I think we all know for initiation it is caspase 8, 9 and 10, and for execution it is 3, 6 and 7. Although I am writing it right away, but I'm watching out for your comments, because the discussion is not for me. Revision is not for me. I have done ample revisions. You know, I'm these days recording even rapid revision videos. So I have done my share of revisions in Hindi, in English. This is for you guys. You need to, if you're typing, very good. Even if you're not typing, you don't want to waste your time and that energy in it. At least say it out loud, because the purpose is that you're away from the INI-CET exam. At least one revision you should be doing with me today. So 3, 6, 7 for execution. For necroptosis, do we have any caspase? No, the definition was caspase independent programmed cell death. For pyroptosis, do I have caspase? Pyro means fever, pyrexia, yes, the cell death with fever. What were those? That is 1, 4, 5 and 11. Repeat with me, 1, 4, 5, 11. All of these caspases are done. But now they ask me, what is apoptosome? Apoptosome is a part of which pathway? Extrinsic pathway of apoptosis or intrinsic pathway? So we are talking about the intrinsic pathway, because in initiation, when you did 8, 9 and 10, remember 8 and 10 were actually taking part in which pathway? That was the extrinsic pathway, and 9 was a part of intrinsic pathway. How did we study this? When I said extrinsic pathway, I studied 8 and X looks like 10. So 8 and 10 extrinsic, and intrinsic of course is going to have procaspase 9 conversion that is happening, and the answer over here. But who converted it? From the mitochondria comes out cytochrome C, and cytochrome C, someone just told me and wrote it in the comments, which is great. From the mitochondria comes cytochrome C and combines with APAF1. Together, cytochrome C plus APAF1 is known as apoptosome, and they are the ones which are responsible for conversion of procaspase 9 to caspase 9. All okay with everyone? I hope you got this right. PYQ tha straightforward tha, so you had to get this right. Moving on to question number 3, which again was a question same for INI-CET, and these are the new pattern of questions that they are giving to you nowadays. This also came, I've not got immediate 1 year back wala PYQs, because I believe those everyone has mastered. I've got a little bit of 3, 4 years purana PYQ, so that in case you've not gone till that depth, you should be knowing it. Which of the following is true regarding sirtuins? The ones which are for anti-aging. Is it made up of CERT1 to CERT7 genes? And the answer is yes. Number 2, what exactly is sirtuin? It's an enzyme called histone deacetylase. Next, I had taught you the benefits of sirtuins are number 1, anti-aging. Anti-aging means that it is going to be involved in longevity, so this is correct. Next, they are saying you can treat them, use them for the treatment of cancer, so definitely they repair a lot of things for me. And you can next use them for treatment of diabetes. If I'm using them for diabetes, they must be improving the insulin sensitivity. So now I come to a conclusion that all the statements mentioned over here were correct, and after this there is no other question of sirtuin that they can ask you. It comes from 7 genes, it's an enzyme, it makes us live longer, it can treat cancer, it can treat diabetes because it improves the sensitivity to insulin, and the short note of sirtuins is done. Well, the only thing extra that they can ask, how should I increase sirtuins? Excellent. If I decrease the calories in my food, by how much percent? By 30%, not much. And if we start drinking more of red wine, I mean, that's not a promotion, but of course this is something which they say that red wine has sirtuins or ability to increase sirtuins in your body. That's how you can live longer. So I've given you a nice takeaway message: eat less, drink more, enjoy life. Anyway, moving on to question 4. This is something where the medicine integration starts. You had a young boy having a lot of bacterial infections with fever and cough, and biochemical analysis have shown that neutrophils have a problem in oxidative burst. Oxidative burst, in very simple words, is phagocytosis. Basically, person has a problem in phagocytosis. They are saying there is a mutation in a gene with which of the following, and out of all of these, all of you call it CGD. So CGD is a problem in what? In NADPH oxidase. If I'm saying NADPH oxidase, what is the gene that they are talking about over here? It is the FOX gene. It is the FOX gene, and as soon as NADPH oxidase is not working, it is actually phagocytosis. Phagocytosis, remember, macrophage eating. Main person causing phagocytosis is NADPH oxidase. My question to you is, once NADPH oxidase starts working, how is the bacteria killed? There is a pathway that is activated. Do you know the name of that pathway? It is H2O2 MPO halide system. It is H2O2 MPO halide system. H2O2, you know, hydrogen peroxide, very, very famous free radical, very deadly. I am going to use this to kill the bacteria now. Now, MPO we know is myeloperoxidase. Okay, so if I say NADPH oxidase is not working, indirectly this will also not work, but the primary defect that I see is of course in NADPH oxidase. Now we come to the third, halide. Halide means chloride. Periodic table, the one you left way back in your 12th grade, that same halide chloride comes up. So this is the pathway that I have activated, and that is how the bacteria will be killed. So now coming to that, if this enzyme is not working, patient has chronic granulomatous disease. Although it was not written over here, but the infections that they would tell me usually are catalase positive. How can we say that? How can we not revise catalase positive? Now we are in a mixed bag GT kind of a phase, right? Tell me the basic 6-7 organisms that come under catalase positive. I'm not writing the full form because you will find it in microbiology, but with me on Monday and Tuesday. But as of now, what all comes to your mind for catalase positive? The famous Staph aureus. You cannot skip Staph aureus. And also S for Serratia. Then P for Pseudomonas. So all these S's are coming together. Staph, Serratia, Pseudomonas. Then we also had fungal organisms. I can think of A for Aspergillus. With C, I can think of Candida. I can also think of Cryptococcus, all the C wale fungus. Then coming to the Enterobacteriaceae family. Enterobacter, basically again bacteria. These are the infections that we are going to have. So now all of that will be seen over here. Lots and lots of catalase positive infections. After that, if I have to do the screening, this question you can never skip, be it NEET, FMGE, INI-CET, any exam, ye to aana hi hai. The screening test is NBT. Do we know the full form of NBT? Nitro Blue Tetrazolium test. Now for INI-CET, I'll tell you something extra, guys. Nitro Blue Tetrazolium test is, what is nitro blue tetrazolium? Blue word is coming. It's a color, it's a dye. Like in path we have everything pink, blue, yellow, right? So nitro blue tetrazolium is the color of a dye. When I will add this dye What color will I get? Will I get to know that patient has this problem or patient has NADPH oxidase? You don't have to know the entire mechanism. You're not going for a short note. You just need to know that if you get a yellow color, this means the enzyme is deficient. NADPH oxidase is negative. This is not there in the rapid revision videos if that's the only module you followed. But if you followed the main videos over there, we had sung a song called Yellow Yellow Dirty Fellow. That is how we were, describing it when our main videos. But even if you've not watched it, not a problem. Now you know Yellow Yellow Dirty Fellow means a person has a disease. So when yellow color comes is when I'll get to know that, okay, this is where the enzyme is deficient. But that's a screening test. What is the diagnostic test that we have? That is DHR. What is the full form of DHR? You have studied again. ये तो RR में भी पढ़ा है. Dihydrorodamine testing. It's reminding me of something. I say dihydrorodamine. कुछ मुझे याद आ रहा है. There are so many Rhoda stuff that we study. Over here you're saying Rhodamine, and then somewhere we have also studied Rhodanine. So Rhodanine is a stain for copper. Remember copper, RRR, copper, R, rhodanine. And rhodamine is going to be for M, Mycobacterium TB, which we will do in microbiology. And यहाँ पे हम पढ़ रहे हैं dihydrorodamine is going to same. This dihydrorodamine is the diagnostic test for chronic granulomatous disease. Let me move on to question 5. This is something which I got mainly from anatomy, histology. These days, they are giving you a lot of those normal kidney pehchano, normal thyroid gland, normal blood vessel. They are more interested in making you identify normal in the INI-CET exam. So this is also one advice to you, that when you go to the histology section of anatomy, make sure you've gone through all the normal cartilages, you've gone through all the normal histology pictures, and then you come to big diseases in pathology. So after an injury, biopsy was done on the 4th day. Even if you are not a fan of pictures, let's ignore it. On the 4th day, the histopathology shows you something. What do I see on the 4th day? And that is granulation tissue, because granulation tissue begins on when? Begins on day 3. That is when the granulation tissue starts forming. And then when does it become maximum? On day 5. And what is granulation tissue? Lots and lots of blood vessels. I can see lots of these blood vessels forming over here. Blood vessel is which collagen? It is collagen type 3. So can you revise all the collagens with me over here? When I say collagen type 1, it's the strongest collagen that we have in our body. Going back to anatomy, collagen type 1 is present in bone, collagen type 1 is present in tendon, and it is also present in skin. Basically anything that signifies strength in your body is collagen type 1. That means starting mein to okay, all this granulation tissue and all you're forming, you can keep doing that, but in the end, when you will make a scar, whenever you get hurt, and the last day, day 21, day 25, when you make a scar, the scar has to be really strong. So can I say the final scar is also going to be collagen type 1? You might start off with any other collagen, that's okay, but the final scar is type 1. Okay, what is type 2? We always learn it as cartilage. Okay, type 3 is present in blood vessels, and that is exactly what is granulation tissue. Granulation tissue is a lot of blood vessels. So then I can say that, okay, type 3 collagen is granulation tissue. Now can we say that when the injury happened and when the patient was healing, starting mein to he made granulation tissue, that is type 3 collagen, but by the time he ended up making a scar, he converted it into type 1 collagen. So in injury, this is a surgery PYQ, that type 3 collagen is now going to change by the end into type 1 collagen. Can we do a ratio for it? Can we do a ratio? Let's see that at the end what is more? Ma'am, type 1 collagen is more. So I will write collagen type 1 in the end is more in comparison to collagen type 3. How much more? What is the ratio? How much does it become more? 4:1. Amazing. We learn 4:1. I hope you didn't learn 1:4, because examiner will write 1:4, 4:1. Options will be like this. But I know that in the end, collagen 1 is more. Where is collagen 1? It's in the numerator. So the numerator should be more, 4:1. If they would have asked me what is the ratio of 3:1, ऐसा लिखा होता, opposite होता, that numerator denominator interchange, then if collagen 1 will come in the denominator, then 4 will, it will be 1:4. तो रट्टा नहीं लगाना, just know where collagen 1 is there, it has to be more, because that's the strongest. 1 is in all 1 things, 2 is in cartilage, 3 is in blood vessels, 4, we always learn 4 is a floor is a basement membrane, right? So basement membrane has collagen 4. Now you are INI-CET students. How can we forget collagen 7? That is something which you will tell me. 1, 2, 3, 4 तो हर student बता देता है. Collagen 7, where is it present, and is there any disease in dermatology which you study with it? So collagen 7 is present in the dermis, the dermoepidermal, below the dermoepidermal junction. Some disease coming to your mind, that is epidermolysis bullosa acquisita. Epidermolysis bullosa acquisita is what you study when it comes to collagen 7 defect. I hope that is okay with everyone. Yes, settled. Can we move forward to the next question that we have? Is, instead of asking you big diseases, I said let me ask them the normal first. Which of the following can change the expression by methylation and acetylation without changing the content? I am not doing gene added or gene deleted. I'm not changing the content. I am only changing the function, and changing the function is known as epigenetics. So now firstly, if inversion would have been then inversion, so ma'am, you are changing the chromosome, you are inverting the chromosome. Chromosome is not being spoken about over here. Over here they're talking about the genes. But I want to ask you, is there a disease? Because the only inversion asked to me is this in almost the entire pathology. Inversion 16 is which blood cancer? 4 तो blood cancer है, ALL, AML, CLL, CML. Which blood cancer shows me inversion 16? How can you forget 4 4s are 16? AML M4 shows you inversion 16, so ये हो गया. Then mutation तो we know DNA changing, that's separate. Amplification, gene is increasing, but they are saying the content of the gene is remaining the same. The only thing that can fit over here is epigenetics. And what do you mean by that? In epigenetics, if I want to change the function, which means either I will tell the gene to keep quiet or you will tell the gene to talk more. So if you're telling the gene to keep quiet or just shut up, basically, in other words, you tell the gene to shut up, you're telling the gene to stay mute, that is done by methylation. If you tell the gene that, okay, please become active, for active, what am I doing? For active, I am doing acetylation. So yeah, I'll just rewrite this in a while when I share the PDF with you. But active ke liye kya hoga? That is going to be acetylation. And now let's try to understand. If I say methylation is making the gene mute, acetylation is making the gene active, ये तो पढ़ लिया. What is deacetylation doing? If acetylation was making the gene active, so removing it, deacetylation will make it active or will make it mute? Of course, deacetylation will make it mute. It's just understanding the concept. Kacha, this I have learned. Now the examiner will change the words and I will answer accordingly. And that is what we call as epigenetics. Now, instead of epigenetics, if they write the literal English meaning of it, it means the same. If they write above genetics, that is the actual definition of epigenetics, above genetics, because in genetics you are doing add a gene, delete a gene, invert a chromosome. You're not doing all of that. You're doing something above it. You are changing the function, mute, active. That is what we call as epigenetics. And I think we all know that when in epigenetics I tell the gene to be mute, what is that mute? Telling the gene to shut up. What is that known as? Imprinting. And do we have disorders which are to do with imprinting? Can you name them? If I say maternal imprinting, paternal deletion, remember that disease, Papa's region deleted. What is the disease over here? I'm talking about Prader-Willi. Yes, this is Prader-Willi. Papa's region deleted and mother's imprinted. It is Prader-Willi. Never ever forget, Papa region deleted. So you will always remember what deleted, what imprinted. Papa region deleted is Prader-Willi. On the other hand, if Mama's region is deleted and Papa's is imprinted, that of course is Angelman syndrome. But what is all of this being spoken about? That is to do with chromosome number 15. Whether I talk about Prader-Willi or about Angelman, it is chromosome 15. But how can the same two diseases happen on the same chromosome? The gene must be different. Can you tell me the gene for Prader-Willi? It is the SNORP gene. When they say SNORP gene, I will be thinking of SNORP P. Prader-Willi. When they say UBE3A gene, I will think of Angelman syndrome. So once what they did is, they also saw our TND videos. They knew SNORP is Prader-Willi, UBE3A is Angelman. So they didn't write UBE3A. They wrote the full form. What is UBE3A, guys? When for INI-CET, you have to know the in-depth part of it. Now you can't just learn mnemonics and expect that INI level questions ठीक हो जाएंगे. It is ubiquitin ligase. So once they didn't write UBE3A, they said there is a defect in ubiquitin ligase, and that means the same. It is UBE3A gene that they are talking about. On the same basis, I gave you a clinical question also, and I hope you could solve it. Severely obese female, history of falls with the crown fracture of the incisors. And then there's mental retardation also mentioned. Typical body habitus of narrow shoulders, obesity. And here comes maternal disomy of chromosome 15. As soon as they say chromosome 15 anywhere in 19 subjects, I think of three things. There are only three things coming to my mind with 15. One is Prader-Willi, of course. One is Angelman that we just spoke about. Anything else coming to your mind with chromosome 15? How can we forget Marfan syndrome? But Marfan syndrome person is very, very tall. All of that is not mentioned here. Marfan out. Ya to ye Prader-Willi ya Angelman. When they say chromosome 15 has only come from the mother. Maternal disomy. See, I am supposed to receive 115 from mother and 115 from father. But here I am saying that I have received both the chromosome 15 from the mother, nothing from the father. When papa's region is not there, it is always Prader-Willi, and that's the chota mota bacha you talk about. The chota mota retarded bacha. The chota mota is short stature with obesity, and retarded, which was mentioned, classical. But the question is why there is obesity? Because of increase in ghrelin. Ghrelin is what makes our appetite go high. High appetite, they eat a lot, and hence they are going to be obese. I think this is also a simple question. Only thing over here that you had to understand was maternal disomy, and catch the point over here. Coming to the next, this I've taken as a PYQ from the FMGE exam. So what I've seen in the recent 2 years approx is that a lot of overlap happens between INI and FMG and vice versa. So for some reason they try to pick up questions from these two places, and NARP has been asked. Out of all of them, NARP has been asked over here. Yes, it is a mitochondrial disorder, and I know the famous thing which I'm not writing, mother to all, father to none, because mitochondrial DNA predominantly comes to us from our mother. But now in the exam, any kind of short form disease put up to me will be indicative of mitochondrial disorder. It is coming from the mother. Quickly revise all these short forms with me, because then I have few more questions for you. Number one short form that you have to know is MELAS, most common na. So mitochondrial encephalopathy, anything encephalopathy, brain, kuch aur hai in the brain, yes, patient is having stroke like episodes. And there is also lactic acidosis. MELAS, repeat with me, this is the most common mitochondrial disease. So chances are if I get a clinical question, it will be enceph with stroke with lactic acidosis. I'll make it MELAS and mark it. Then I see a lot of things happening in the eyes, because mitochondrial diseases tend to affect the eyes a lot, either the eyes or the retina or the eye muscle. Like over here it affected the eye muscle, over here it affects the optic nerve, something to do with the eyes will be there. So what is CPEO? Chronic progressive external ophthalmoplegia. This is affecting the eye muscle. So this is the most common myopathy of mitochondria. Most common mitochondrial myopathy, CPEO. Then when I say optic neuropathy, to LON ho gaya. Then we come to NARP. What in NARP is obviously neurogenic ataxia. There is neurological problem. But RP kya hai? Retinitis pigmentosa. Again, this is going to be involvement of the eyes. Then we have Leigh syndrome, Pearson syndrome, Kearns-Sayre syndrome, and this has been a recent question again. They said there is a disease going from mother to all, father to none, and then which of the following fits into it? Options had Kearns-Sayre syndrome. So please don't end the list here. Read all the names and go. And what I think in the exam could come now is MRF. What is MRF clinically? Sabse pehle patient has myoclonus, then patient has myoclonus epilepsy. What is RRF? There are going to be red ragged fibers. Earlier they used to give images. I've taught you in rapid revision, but now they've stopped giving images. They just ask you theoretically, do you know the meaning of what are red ragged fibers? I can understand that, yes, even in NEET that question came, correct? So now tell me, red ragged fibers kya hai? Kahan ban rahe hain? Where are these fibers forming? Because the problem that I can see is in the muscle. So these red ragged fibers are actually forming in the muscle. And what are these red ragged fibers? They are nothing but abnormal mitochondria, because ultimately this is a mitochondrial DNA problem, na? So that is a mitochondria. Again, as I said, in your rapid revision I've shown you images, but I'm not showing you images today because they've stopped asking you those images. They are asking you either the diagnosis directly or they are giving that information. So if I say they are looking like red fibers, you'll say okay, they are abnormal mitochondria, but mitochondria kahan dikhta hai? On that black and white electron microscope. So how does the mitochondria mitochondria look like on electron microscope? Either it looks like in the olden days we didn't have Spotify for our music. We had those phonographic records on which all the songs used to play, right? So either the mitochondria looks like that round disc of phonographic record, or the mitochondria looks like pretty much how parking is done anywhere in any city of our country. That is, anywhere randomly parking lot appearance. Any mitochondria is parked anywhere in any direction. So the mitochondria either look like phonographic records or they look like parking lot. And if they are asking you that how are they appearing in the color, special stain पे कौन सा color? Red ragged fibers. Everything over here is to do with the mitochondria. Because it is involving the muscle, there is also myoclonus epilepsy that these patients have. This is something I feel INI-CET में आपको, they won't give you photos, they'll give you more of, because photos have become very evident now. कोई भी पहचान लेगा ना parking lot appearance. They'll give you written that okay, there is a patient showing this, and now you have to come to a diagnosis of MRF. Moving on, NARP is mitochondrial. There is karyotyping that is given, and I assume everyone could easily pick up the 47XXY and make it a case of Klinefelter, which was not very tough. And when I say Klinefelter, these patients having it's a male, right, but having extra X, so there's gynecomastia, they have very long limbs, they are overall very tall. And if I ask you 2-3 very quick questions, in Klinefelter, what is the cardiac abnormality that these patients have? That is mitral valve prolapse. And now remember, whenever a combination of mitral valve prolapse and a person being very tall comes, number one, you will be thinking of Klinefelter, obviously. Another thing you can think of, chromosome 15 person with mitral valve prolapse and being 9 feet tall, very, very tall. Marfan's also has the same combination, but Marfan's was a problem in chromosome 15, which I don't see anywhere over here. And this is Klinefelter having a problem in XXY, as you could see in the image provided to you, XXY given. So this is Klinefelter, of course. Now, what is the other most common cancer that can occur in Klinefelter? It's obviously a male, so we will think of male breast cancer. The only 2 questions of male breast cancer that come to you in surgery is number 1, the association with Klinefelter, and number 2, male breast cancer is BRCA which mutation? BRCA1 तो सबसे common females में होता है. Males में it is BRCA2 gene which is actually a problem. So male breast cancer either Klinefelter or it is BRCA2. The next question of Klinefelter coming is there an autoimmune? I think ऐसा कुछ आएगा अब. Is there any autoimmune disease with which it can be associated? And that is SLE. Many Klinefelter patients have been shown to have SLE, systemic lupus erythematosus, very important. And of course, the next is what is the hormone profile? Pretty obvious. Extra X chromosomes are there, so the testosterone levels will go down. It's more of an estrogenic state. That is why the gynecomastia is happening. And if testosterone goes down, then by feedback, the LH-FSH is going to go up. These are all the questions of Klinefelter that they can actually catch you in. But now coming to the point that what was this technique? वहाँ जाने से पहले, if I would have said webbing of the neck, तो you would have thought of Turner's, which was what? Which is 45XO, obviously. If I say polydactyly, P for polydactyly, P for Pettau syndrome. Pettau syndrome is trisomy 13, which I would think of. Now let's come to this. It is karyotyping. Anything I think of chromosomes. So keep a rule in life. 3 words, which I will write in a while, but अभी 3 words ऐसे याद रख लो that how should I just quickly solve a question in 2 seconds. Chromosome कुछ भी आएगा, I will think of either a karyotype or I will think of fish. Repeat with me, anything chromosome because ये सब आगे questions है. Chromosome is either karyotype or I will do fish. If they say genetics, mutation, gene mutation, point mutation, silence mutation, कोई भी mutation genetics में आ रहा है, I will think of PCR. And if they say CD markers, I have to test CD1, 10, 20, 40, any CD marker, I will go for flow cytometry. These are all 4 questions. Chromosome के लिए repeat with me, karyotype and fish. Gene mutation, gene कुछ भी होगा, then I'll think of PCR. And if I have CD markers, I will think of flow cytometry. If you keep this sorted, most of the questions coming up today and tomorrow will also be easy. And right now I'm talking about chromosomes, so karyotype. And meanwhile, I was seeing that all of you were very kind to give me answers. Karyotyping is done in which phase? It is done in metaphase. You will say tell the chromosomes to get arrested in metaphase by adding which chemical? By adding colchicine. Then what is the fixative? And by the way, this came as a PYQ in INI-CET. INI-CET again 3 years ago if I'm not mistaken, and they told you to put everything in a correct order on how karyotyping is done. So let's assume you took an amniotic sample, amniotic fluid, amniocentesis from any female during her pregnancy. First thing you will do is you will which phase will you arrest the chromosomes in metaphase by adding colchicine. Then you will be adding a fixative. Carno is fixative, yes. So for we had learned car, yo, car, noi, car, yo. I want to ask you, I'm not writing it again because वो शायद कल कहीं लिखेंगे. Is there something called Carney's triad? Is there any tumor with which we associate this with? Carney's triad. Yes. कुछ triad है, something with a stomach tumor. I'll leave that open-ended. Gist hai, gist very good, but rest I will discuss tomorrow because maybe something is coming tomorrow. But anyway, that is Carney's triad, वो diseases वाला है. This is karyotyping का Carnoy fixative, which is methanol and glacial acetic acid in the ratio of 3:1. That's important, the ratio. Methanol and glacial acetic acid 3:1. That also we learnt as Carnoy only. 3:1. C and A, third alphabet, first alphabet. So 3:1. Finally, I will add some colors. Like this is looking pretty black and white types. Why? Because this is the Garib wala Jimsa stain. That's how we learnt it. Why Garib wala? Because I'm using the Garib wala microscope, ma'am, the poor microscope which everyone has. So light microscope. But if I want to make this a little fancy, which stain will I use? I will use quinacridine stain, and for the queen you will use something fancy. So that is fancy fluorescent microscope. One question for microbiology. Maybe you will find it in that. Maybe not this, but fluorescent microscope आएगा ना, micro में question आएगा. What is the light that I use in a fluorescent microscope? Is it the usual light bulb that I have in front of me right now, or is there a special type of light so that the fluorescence can be seen? UV light. Whenever UV light पे, I think there are 3 questions. I'm going very random over here because it's a discussion, right? We can take up other subjects. So UV light पे 3 questions आ सकते हैं. Fluorescent microscope uses UV light. I remember in neoplasia I taught you which UV light is the most dangerous from the sun, which is going to cause cancers in us. It is UV A, B and C. So we had studied UV B is very bad. UV B causes bad wala cancers in us. Okay. Third question, I think in dermatology you are asked कि wood lamp में क्या use करते हो. Remember that wood lamp examination with which you look at all the skin rashes and skin lesions in derma. So in that you are going to use UV light again. So these are 3 very important UV related questions that you are going to get. Anyway, we'll talk more about that. I think you are done. Pehle arrest kara, then fixative, then you are going to do G banding or Q banding. So you know which microscope to use, but most common banding if ever asked, it is the usual Garib wala light microscope wala G banding. That is done. Is that okay? Question 10 moving on to, now I said most of these will start coming up. Which of the following options is not used for detecting genes? So when I said genes, I told you na PCR सोचना, this is a PCR, this is a PCR, this is also a type of PCR which is not used for detecting abnormal genes. Flow cytometry, because ma'am you taught us flow cytometry is for CD markers. If you want to know, tell me a disease in which कल पढ़ोगे CD55, CD59, कौन सी disease? If you want to find out CD55 and CD59 is present or absent, PNH. So any disease talking about CD markers, you will be doing flow cytometry, but that's not how they write it. CD markers is what? If this is a cell, CD marker is present on its surface. I'm trying to know the immunophenotyping of that cell. ऐसा बड़ा सा नाम लिखा that, oh, you are wanting to do the immunophenotyping testing of a cell. It's very simple. They've just given it a very fancy name. It just means you're trying to find out CD markers, and how will you do that? With flow cytometry. Everything else of course is going to be for genes. Let's quickly discuss what is this entire PCR thing and what are these different PCRs. Pehle to you tell me just the PCR, because 2023, again I might be mistaking 1 or 2 years here and there, but I remember the November session of INI-CET had this question of PCR, and very basic they went on to कि अच्छा, tell me the basic steps of PCR and arrange them in the correct order, and that is exactly what we start with. The correct order is D, A, E. That's 3 steps. What do you do first? You take a DNA, we know double-stranded DNA, and you convert it into a single-stranded DNA, that is known as denaturation. After you converted it into single-stranded, now you are going to attach something. I will attach 1 primer here and 1 primer here so that I can make new DNA. So that attachment is known as annealing. Okay, and after that they will say कि अच्छा make new DNA, and that is going to be extension. So that's the third step that we have. So you don't have to learn DAE कुछ ऐसा mnemonic नहीं याद रखना. You just have to be very obvious in this, that first I will separate the DNA called denaturation, then I will attach the primer, one primer here, one primer here. So if you're attaching one primer, that's like regular PCR, and then you extend it, so that is known as extension. But what if I want this to be a little faster? You are attaching one primer here, dheere dheere things are happening. But if I now attach two primers here on every strand, if I start using two primers, that's known as nested PCR, and that's what came in the 25 exam that you were telling me right now. So nested PCR, like a nest is made of a couple of birds, so two birds, a couple, two birds are going to sit in a nest. So same way, two primers are going to be used in a nested PCR. Very, very important for you to know. Nested PCR, how many primers? Usual PCR, I use one primer. Every DNA, one primer. In nested, nest of two birds, so I'm going to use two primers just to make it a little faster for me. So I think this question is done. When do I use RT-PCR, reverse transcriptase? When I'm dealing with RNAs, because first I will convert the RNA to a DNA, I will do reverse transcription, and from there I will go on with the rest of the PCR over here. So please note that this is coronavirus, we were doing RT-PCR. In coronavirus, was I doing only RT-PCR, or am I still prevalent? Am I doing RT-PCR? Because RT, I understand reverse transcriptase. What is the small r that I've added over here? Small r is for real time or quantitative. Whenever I have to count something, now keep that in mind. Any XYZ clinical history they give you, and they say you are wanting to count something, like you are wanting to count the viral particles or the viral copies. Let's give you a case of what is this translocation 922 क्या होता है? Philadelphia chromosome. So basically CML, right? You want to count the number of 922 copies. How many fusion copies are there? You want to count anything and any number of copies of anything on this planet. For counting, you will be quantifying, you will be using real-time PCR. So in COVID, I'm doing a combination of RRT-PCR. Let's move on to the next. This is where I want you to know a biochemistry update. Pyrosequencing is whenever I have a low tumor yield. They say that you have got only 8, their favorite number is that you have got 8% tumor cells. You want to do a PCR because your tumor cells are very less. You know, sometimes patients before, let's assume you are doing a breast biopsy, but patient has already received radiotherapy before that. So the tumor count has gone down. Now you have only 8% cells left. In that you have to do a PCR, so you will do pyrosequencing. But the biochemistry update says that till the time the PCR was asked for low tumor yield, you said pyrosequencing PCR. Is there a technique which is better than PCR for this? And that is next generation sequencing. If ever, next generation sequencing and pyrosequencing both are in the options for low tumor yield, the better answer than PCR will be NGS, next generation sequencing. So all of these are definitely used for gene stuff, but flow cytometry is not. That is for CD markers. Similarly, we had another question on PCR, and that is the reason that I've kept a certain order. Obviously in the exam itna zyada orderly nahi hoga, but you must have seen I'm going in the order of chapters because I wanted this TND to be something like a quick go through of all your notes while you are doing questions also. There is a 40-year-old man, chronic smoker, 20 years, having fever and weakness. CBC hemoglobin levels are very high, 18 gram. For a man, anything above 16.5, I am worried. For which disease? For polycythemia. But right now I also know he's a smoker, so maybe that hypoxia has caused it. Let me read further. I realize his total leukocyte count is also 30,000. The normal total leukocyte count is 4K to 11K. Normal adult ka 4,000 to 11,000, so it is increased. Platelet count is also raised. Now if he would have been, if this is because of only smoking, what happens with smoking? When smoking, ma'am, obviously there is hypoxia. Whenever your body goes in hypoxia, your body starts producing a lot of erythropoietin, and that is why the hemoglobin in smokers is usually on the higher side. And in the blood bank, I have to be very cautious. Maybe someone has come to donate blood. His hemoglobin is showing 12.5, which is the cutoff for blood donation. And I did not ask for his smoking history. Maybe originally his hemoglobin is not 12.5 because he is a chronic smoker. His hemoglobin was probably a 10 or an 11 but because of that smoking, the EPO hypoxia has caused it to be falsely 12.5. So asking for a smoking history is so important. But then I saw EPO levels are suboptimal, means this is not to do with smoking. Smoking is just a random history given. Here the erythropoietin levels are below normal, and still all of this is happening because we are now suspecting. I'm just teaching you, although in the exam it was written straightforward, it's a case of polycythemia vera. And I know all cases show me JAK2, to be very precise, JAK2 V617F mutation. So I know the exact codon at which it will occur. When I know the exact base at which the mutation is occurring, which PCR do I use? Single base primer extension. So let's start studying with this. Single base primer extension mein I know exactly which codon. I'll give you more examples. Let's say they give you me a case of BRAF V600E mutation. If they say exactly at 600 codon you have to do a thing, so I'll say, okay, I will use single base primer extension. Anything where the codon number is mentioned, answer single base primer extension. Apart from that, RT-PCR I have already taught you for COVID RNAs. Pyrosequencing for low tumor yield I have taught you. What is this? Amplicon length analysis. When do I use this? Whenever I have extremely lengthy DNA. Length analysis kab use karenge? When ma'am you will have lengthy DNA, like in Fragile X syndrome as an example. Can you tell me why is the DNA lengthy? Which repeats have made it lengthy? CGG karte the DNA becomes very lengthy. Hence I will use amplicon length. But now coming to a quick revision of this, if it's a case of polycythemia vera, can you tell me the criteria in medicine for PV? Major criteria, minor criteria. Major criteria says number 1, hemoglobin should be more than 1. If it is more than 16.5 grams in males and it is more than 16 grams in females, I will be worried. That is hemoglobin. But the rule is that after this, I have to make sure that I prove JAK2 V617F mutation. That you have to prove. And then in the bone marrow, you might feel, oh, this will just be an increase in hemoglobin. No, I see everything is increased. It is a pan-myelosis, RBC, WBC, platelet. Tell me one clinical feature because of this. When they will say RBC, hemoglobin bada hua hai, you will, what is the color of the face that you will notice? A red color face called the plethoric face is going to occur because hemoglobin zyada hai. So the color of the face changes. When the WBCs are more, this is the most famous thing they ask you. Patient goes to take a bath with hot water. After taking a bath, he starts feeling itchy. Usually it's the other way around. We feel itchy, that is why we take a bath. But this patient ke saath ulta ho raha hai. He goes to take a bath and after that he comes back itching because hot water came on the skin. Skin mein kya badha hua tha? The WBCs were increased, na? Which WBC? Mast cells. They were increased in the skin. As soon as hot water came on the skin, those mast cells, they burst. And mast cell releases what? Richest source of histamines. Histamine is causing pruritus over here. Aquagenic pruritus is their favorite thing. Patient goes for a hot water bath, hot water shower, and he comes back saying, I'm feeling very itchy. If you said this is because of mast cells, one question for all of you, what is the special stain for mast cell? What is the special stain for mast cell or basophil? It is toluidine blue. Special stain for mast cell or basophil is toluidine blue. Again, an INI-CET question. Okay, WBC increases. Now, platelets are also increased. Likha tha, platelets are raised. Though so many. Normal platelet count is how much? Normal platelet count is 1.5 to 4.5 lakhs. I say now the platelet count is more than 4.5, 5 lakhs, 6 lakhs. I have seen 10 lakh platelets also in these patients. Platelets are so many in lakhs. And the blood vessels of my fingers are so patla, they are so thin. Those platelets will get stuck and they will result in what? That is erythromelalgia. No, erythro over here does not mean RBC. Erythromelalgia is the patient will say, my fingers are burning, my toes and fingers. Wherever small blood vessels are there, he will say they are burning because those platelets are blocking them. So these three words, plethora, aquagenic pruritus, and of course erythromelalgia. Remember it for polycythemia vera, but these were major criteria. Don't forget the minor criteria that all of this is happening when EPO is either normal or decreased. Matlab EPO can never be increased, because if EPO is increased, then the story totally shifts. Then it is to do with hypoxia and high altitude and smokers and all of that. So EPO should be normal or decreased, and that is exactly what was written here. तो पूरा PV भी discuss हो गया. आगे चलते हैं. Coming to 12. This is not there in rapid revision videos, but time and again I have told INI-CET students to read this from main videos only for the INI exam. Not important for NEET PG also. Did you attempt this question? Risk combines with what? Risk combines with single-stranded microRNA. Now, what is microRNA? And this is, I think, a tougher thing for today. थोड़ा सा extra पढ़ना पड़ेगा, but then it's INI, so I have to give it that extra edge, right? When I say microRNA, it's a छोटा RNA. Roughly 20 to 22 nucleotides will be there. That is why I call it छोटा RNA, microRNA, but it is non-coding RNA. See, in biochemistry you study coding RNA and non-coding RNA. RNA is supposed to make what? If it's talking, it will make what? DNA to RNA, RNA to protein. If the RNA is making protein, means it is coding. If the RNA is not making protein, it is non-coding. So is it going to go further and make a protein? No, it is not. Hence I call it non-coding RNA. अब हमारी body में होता है. This is normally present in our body, and listen very carefully. There are microRNAs normally present in our body, which I will tell you what job they do. But how are they formed? RNA बनेगा तो DNA से ना ma'am. So you have made a DNA over here. This is the typical double-stranded DNA, and from there you wanted to make an RNA. But this time you are making something different. You are not making a regular RNA. You are not making a coding RNA. You are making microRNA, which is non-coding, and that is the first one. That is, yes, what is this microRNA? But I can see so many of them. I can see so many of these microRNAs formed. Then you are like, nahi ma'am, in sab mein se sirf ek cut out kar lo. Just cut out one microRNA, like you are taking a scissors and cutting it out like this. So which is the scissors? Can you name the scissors which is going to cut so many microRNAs into chota microRNAs? What are those? What are those known as? DROSHA and DGCR8. That's why I said na thoda sa tough yahan pe hoga. DROSHA and DGCR8 are the two scissors with which all these many microRNAs you have cut into chota microRNAs. Single, ek alag, fir isse alag, fir isse alag. But all of this was happening in the nucleus. Now you say all these chota pieces can move out of the nucleus in the cytoplasm. Can I say that you are exporting them out through a gate? You are telling them to get out. What is the name of that gate? That is known as exportin 5. I hope it is visible. Exportin, the name tells you na export. So now you are just exporting it out and it has come out in the cytoplasm. But then you realize that ये single भी बहुत है. इसको भी behead it. Cut the head of this microRNA. So I decided now to cut the head of this microRNA over here. Who will cut the head of this? Like you are dicing. Have you all played in your teenage or college life? Have you played that game Fruit Ninja? किसने खेला है नहीं खेला है? Or am I too old and I'm giving you a very oldie reference over here? Have you guys played Fruit Ninja? A game on your phone or your iPad or tablet where those, especially watermelons and fruits, come in with your finger with a sword. You have to slice them out. Dice करना होता है उनको. That is Fruit Ninja. If you haven't played, today's homework for you. Download Fruit Ninja and play it. It's a nice stupid game but very nice. So you have to dice the fruit. Same way. उसमें क्या होता है? Fruit को ऐसे behead करते हो, cut करते हो. Same I have done. I have diced this particular microRNA. I am just left with these two strands. But that is double-stranded. How can RNA be double-stranded, ma'am? You converted this double-stranded RNA into single-stranded microRNA finally. And that is where the story is completed. You have finally made single-stranded microRNA, and this single strand will now go and combine with something called RISC. Now when you'll know the full form of RISC. Okay, someone who's not played, never mind. Today, so usually everyone gives you academic homework. I think I'll be the first person who's giving you a homework to download a game, but don't download because it's addictive also. The dumber the game, the more addictive it is. Exam में time waste होगा. Exam के बाद download करना, Fruit Ninja खेलना. But anyway, microRNA finally comes and combines to RISC. What is the full form of RISC? It is RNA induced. Can I see the RNA coming? Yes, the single-stranded microRNA is coming. What is it doing? Silencing. Will it make protein? No, it will not make protein. So that is known as RNA-induced silencing complex, which is known as RISC. And now you understand na, that, oh, okay, this is basically like a big taxi and it is going to take this microRNA, and will it make protein after that? Not at all. This is a non-coding RNA. It will not make a protein. And then they asked you, RISC combines with what? अगर पूरे में से मुझे दो questions निकालने हैं. RISC combines with what? RISC combines with double-stranded microRNA or single-stranded. So that is of course only single-stranded microRNA. Now, how did this form? How did you cut the head? With dicer. So if there is a dicer mutation, this you will tell me from gynae. Is there a gynae ovarian tumor that can occur because of dicer mutations? They have been associated with sex cord stromal tumors of the ovary. Sex cord stromal tumors of the ovary have been associated with Dicer mutation. Very very important. Second question. अब INI-CET है तो एक third question भी बनता है. For that you will tell me, have you heard of course you've heard of a leukemia called CLL. What is why does CLL occur? Which is the deletion of chromosome in CLL? अच्छा, someone said Sertoli cell. बिल्कुल Sertoli cell testis में चले गए, but that is also a sex cord stromal tumor. Any sex cord stromal tumor that they write in the exam will be your safest answer. Sertoli cell tumor, Leydig cell tumor, फाइब्रोमा थिकोमा भी हो सकता है. तो बेसिकली एनी सेक्स कॉर्ड स्ट्रोमल ट्यूमर. सर्टोली लेडिक भी लिखा होगा तो चलेगा. CLL, व्हाई डज CLL occur? Very good ma'am, this is CLL is occurring because of deletion 13q. Okay, so deletion 13q means the long arm of chromosome 13 is getting deleted. But do you know what is पूरा arm? ऐसे पूरा arm is not getting deleted. One tiny little part of it is getting deleted, and that tiny little part is actually microRNA 15 and 16 which is getting deleted. When I say na 13th chromosome got deleted, it's which part of the 13th chromosome getting deleted? microRNA 15 and 16, and now you know everything about microRNA. So your take home message has 3 points. Finally, कौन सा वाला microRNA बनेगा? Single stranded. Second question, Dicer mutation, sex cord stromal tumors. Third question, microRNA 15 16 deleted in which blood cancer? CLL. Okay guys, moving on to question 13. I think another one which was more from the main videos. A 30-year-old man with multiple soft tissue swellings which are attached to the nerves, something neural. Neural sunte hi two things come to my mind. Either it is a neurofibroma or it is a schwannoma. These are the only two nerve tumors that I know of. So I will take a guess on that. Multiple pigmented lesions are seen. Is this with neurofibroma reminding me of cafe au lait spots? Maybe. And then after that, ophthal examination shows some hamartomatous lesions. Is this reminding me of some nodules that you see? Because by now, schwannoma is out of question. मुझे ये पक्का neurofibromatosis लग चुका है. I think this is a case of neurofibromatosis showing me cafe au lait spots, and yes, in which part of the eye? In the iris I can see leash nodules. This is a case of neurofibromatosis. Now this could either be neurofibromatosis 1 or neurofibromatosis 2. I think it is neurofibromatosis 1. Why am I so confident on this, guys? Any reason that I am saying, no, this is not NF2? Firstly, NF2 mein there are more of schwannomas which are not, they didn't write anything, nerve likha tha, so that I can't take a guess on. But leash nodules, अच्छा, no, this is not Irish nodule. Irish node कहीं और पढ़ते हो. पहले let's figure that out. Irish node कहाँ पढ़ते हो? Then I'll come back to this because leash nodules is what actually makes it NF1. तो leash nodule तो I understood that you see it in the iris and you see it as ophthal examination. Irish node कहाँ पढ़ते हो? Because you know these are the kind of fancy words ना. Anyone can make an error exam में. GI cancer. Which GI cancer? Stomach cancer. When the stomach cancer spreads to where do you call it the Irish lymph node? When stomach cancer goes to axillary lymph node. Remember this. I'm leaving this topic for exactly 30 seconds. When the stomach cancer goes to the axillary lymph node, that is known as Irish node. When the stomach cancer goes to the left supraclavicular lymph node, that is the ultra famous Virchow's node. Axillary में गया Irish node, left supraclavicular गया, that is the Virchow node. Yes. And when stomach cancer goes to the ovary, anything going to the ovary is known as Krukenberg tumor. Okay, when stomach cancer goes to peri-umbilical region, I think this was like the pass-fail question in our final prof. When stomach cancer goes to peri-umbilical region, it is Sister Mary Joseph nodule. तो वो स्टमक कैंसर था, वो हमारा आयरिश नोड वो अलग. वॉट यू सी इन द न्यूरोफाइब्रोमेटोसिस इज लीश नोड्यूल्स. सो आई थिंक वी आर सेटल्ड. नाउ कमिंग बैक, द क्वेश्चन वाज नॉट दिस NF1 हो NF2 हो, दे सेड विच मैकेनिज्म इज रिलेटेड विद दिस म्यूटेशन. फर्स्टली व्हेन आई टॉक अबाउट NF1 एंड NF2, कैन यू टेल मी द क्रोमोसोम्स एसोसिएटेड विद इट? NF1 को उल्टा पढ़ो, इट बिकम्स a 17, दैट्स द क्रोमोसोम. NF2 इज 2, सो क्रोमोसोम 22. बट ये भी आंसर नहीं है. आंसर पूछा व्हाट इज द मैकेनिज्म एंड द आंसर इज गोइंग टू बी option A. Some of you said option D, decrease susceptibility to apoptosis. No, that is not the mechanism. I'll come to this one by one. Let us understand this better. Basically, it is the activation of the RAS gene. Have you all heard of RAS, the most common oncogene, cancer causing gene? And I've taught you a mnemonic in neoplasia. RAS tak kahan hai? So we have KRAS, HRAS, NRAS. Yes, the same RAS I'm talking about. But now in your main videos, you study how does RAS work. RAS has an entire pathway जो चलता रहेगा. That I don't have to know. But do you know, whenever I have to make RAS work, and listen very carefully, if you want RAS to work, RAS says, if you want me to work, you will have to give me some energy, some food, then I will work for you. To give it energy, you said, okay, I will give you some GTP. Like we work on ATP, RAS will work on which energy? RAS will work on GTP. So till the time you keep giving it GTP, RAS will keep on working. But if ma'am, RAS keeps on working, I will end up with cancers every day. So then I decided RAS will work sometimes. When it will work? When I give it GTP. And after some time I will not give it GTP so that it stops working. Balance maintain kar liya. But just imagine, if you are giving it GTP, very good. At some point of time you will have to stop giving it GTP, otherwise you will have cancer. So how do I stop giving it GTP? I have an enzyme called GTPase जो GTP को break कर देगा. So can I say that is known as GTPase activating protein? GTPase will break, and you're everyone, are you with me on this? Are you understanding the balance, that 100% of the time if RAS will keep on working, so we will to have cancers tonight and die? I don't want that. So I said stop the GTP, stop the RAS. Once in a while balance is important. How do I stop it? By the GTPase activating protein, and that is exactly what NF is. NF is going to be related. It is a GTPase activating protein. Normally in our body, forget the disease, NF gene जो है हमारा बॉडी में, it is a GTPase activating protein. What does it do? NF goes and it stops the GTP from working so that you can stop the RAS from working and you don't have cancers. But I am saying there is a mutation. NF is mutated. If NF is not working, this means the gap function is not working. There is no one to stop GTP, and GTP will keep on working, RAS will keep on working. There will be persistent activation of the RAS gene, which was the answer over here. So normally what is NF? NF is a good man. NF is gap protein. NF protects me from cancers. Can I call NF as a tumor suppressor gene? Coming back, so if NF is mutated, that is going to result in what? That is going to result in persistent activation of RAS, and that is the mechanism. I hope you understood NF1, NF2 का mechanism, because NF1, 2 तो हम पढ़ते हैं, but the mechanism is important. Coming to question 14, another recent INI exam question, and that is anaplastic lymphoma kinase. Anaplastic lymphoma kinase, ALK gene expression. Quite entertaining emojis are coming up on my head. But anyway, avoid the entertainment and focus on this. ALK gene, inflammatory myofibroblastic tumor. That is a question that I expect in INI-CET. ALK gene is associated with what? Firstly, ALK के तो नाम में ही है. Which lymphoma can it cause? Anaplastic lymphoma. This was the recent exam question. Which translocation? Because anaplastic lymphoma kinase gene is present on chromosome 2. So anything with chromosome 2 translocation like 2 and 5 is anaplastic lymphoma. That is number 1. A for ALK gene, A for adenocarcinoma of the lung. And lastly, this is always I've taught you for INI-CET students, ALK gene is associated with inflammatory myofibroblastic tumors. So that's a ratta question. But I have some other questions for you. Ewing sarcoma, bone tumor. How can you forget in radiology? In radiology, you have that classical onion skin appearance in Ewing sarcoma. Then tell me, what is the translocation of Ewing sarcoma? E से हमने याद किया है 11, and sarcoma can look like a 2. So 1122. You can't afford to forget 1122 for this. Now remember, what are the genes? Ewing's sarcoma का gene कौन सा? Ewing's sarcoma, EWS. And we always studied wings help you fly. So what is the other gene with which it will get mutated? It is the fly gene fusion. So EVS and fly gene fusion will be seen in Ewing sarcoma. But come to pathology question. In this bone tumor, which CD marker can be positive? AIMS का तो when INI-CET was not in the play and it was AIMS अलग, JIPMER, PGI अलग ऐसा चलता था, तो AIMS का तो it was a sure shot question every year. Ewing sarcoma is CD99, also known as MIC2. If you go to those prior to 5-6 year PYQs, MIC2 in Ewing's is a question you'll see in every paper of AIMS. Biannually you will see this question. So MIC2 or CD99 for Ewing sarcoma. Okay, now moving on. I hope this is done. Iska to simple answer tha, nothing more to study here. Question 15. Which of the following is an incorrect match? This was not a question where you had to know every option. Do I want you to know at every place where amplification or mutation is occurring? No, but I wanted you to be smart here. Okay, JAK is mutation. I think I know this because I've already taught you JAK2 V617F. It occurs at a point. So yes, it is point mutation. Yes, it causes polycythemia vera, that is right. PDGFR beta we had studied in neoplasia for brain tumors. Yes, it causes gliomas. Is it amplification? Maybe, maybe not, I don't know, but आगे पढ़ते हैं. RET, point mutation. How can I forget this? RET10 MED-MEN. RET is what? The name of the gene. The chromosome on which it is present is going to be chromosome 10. Which cancer does it cause? MED, that is medullary carcinoma. And which syndrome with which it is associated? MEN2A, MEN2B. So ये तो ठीक है. But is this a point mutation? Yes. Can you tell me which gene mutation results in medullary carcinoma thyroid? Is the red gene working more or is it working less? Is it a gain of function or a loss of function? Cancer karana hai, so obviously the gene is working over time. That is why cancer is happening, ma'am. The gain of function is going to cause medullary carcinoma thyroid, because what if red gene stopped working? Do you know any gene in any disease in pediatrics where the red gene stops working? And that is Hirschsprung disease. What is Hirschsprung disease? What cells are missing from the intestine? The ganglion cells go missing. Aganglionosis. So remember, if the gene is working more, cancer hoga. If the gene is working less, then the ganglion cells are not formed, and that is going to be Hirschsprung's disease. Is that okay with everyone? मूविंग ऑन. तो ये तो सब ठीक ठीक लग रहा है. दिस इज, ये भी तो ठीक है. BCR ABL रिजल्टिंग इन CML, दिस इज ऑल्सो राइट. बट इज दैट अ पॉइंट म्यूटेशन? आई मीन मे बी आई डिडंट नो, बट यहाँ पर आके आई रियलाइज दिस कांट बी अ पॉइंट म्यूटेशन, बिकॉज BCR and ABL are not point mutations. They are translocation 922, what I call as Philadelphia chromosome. So the incorrect match is right staring in front of me. Even if I didn't know the other options are mutations or amplifications, doesn't matter. This though I know is definitely wrong, and that's how you had to approach this question. This is not a mutation, this is a fusion, Philadelphia chromosome. For INI-CET exam, tomorrow this will come again, but anyway, when Philadelphia and BCR ABL fusion happens, the weight of this fusion protein will determine what kind of a cancer will occur. How did we learn the weight? 20-20 ka increments. Either the weight of this fusion is 190 kilodalton. If you add 20, it becomes 210 kilodalton. You further add 20, it becomes 230 kilodalton. And whatever the situation is, now the cancer will vary accordingly. And we had learned the cancer as LMN. 3 blood cancers hote hain. The first one is to do with ALL. The next one, how can I forget the Philadelphia main one, CML. And the third one is chronic neutrophilic leukemia, that is CNL. So in the exam, remember 20-20 increments, 120, 210, 230, and remember LMN in the same order, so that you know that okay, this same translocation and same fusion can result in 3 cancers for me. All good till now. So I've got 15 questions done. Thank you so much.